Hello, good afternoon, everyone. Welcome to today's Complex Pediatrics Echo Clinic. Thank you for joining us. We'll start off with introductions for today. So hi, I'm Troy Jorgensen, Program Manager, Project Echo Nevada.
Amy Smith, Program Assistant.
Dr. Kip.
I'm Katrinka Kipp. I'm one of the local pediatric cardiologists and your speaker for the day.
I'm Kathy Eckert. I'm a pediatric endocrinologist.
Dr. Lansing, I'm a pediatric clinical psychologist.
Okay, doesn't look like we'll have any cases for today, but if there are any that come to your mind while we're going through the presentation, please feel free to chime in and ask those questions. So we'll get going with the presentation here then. So we're going to go to the next slide. So that was just our, go back, sorry. So just a disclaimer that we do record all of these sessions and we're building a resource library for everyone to be able to refer back to and have this as a lasting resource. And then if you do present a patient case, just remember not to disclose any HIPAA protected information, no protected health information, that type of thing. So we'll get going here then.
Good afternoon. Thank you guys for joining me from wherever you are. Kind of a diverse geographic and education level or interest. I am a pediatric cardiologist locally, and the reason I picked syncope and chest pain in the pediatric patient is it's something that I see very frequently, and I know that the primary care providers see it also, see patients with this extremely frequently. So I thought I'd go over what exactly you would want to know by history, physical exam, and you know, when to refer and when you don't have to refer if you choose not to. So as I said, I'm going to try to let you know about how to evaluate, treat, and I think the most important thing with this diagnosis is to reassure the patient and the family. So there are no conflicts of interest. The learning objectives, I want people to understand what the most common causes of chest pain and syncope are in this population. I want you to know what history points are very important to inquire about. I want you to be able to see what you might recognize on physical exam, what testing should be done, and you know when people should clearly be referred, and when, if you choose not to refer, when that's perfectly appropriate. And the reassurance part, I keep going back to that because it is a huge part of taking care of the patients with these complaints. So we see a ton of patients with chest pain and syncope. As of August 6th, we went through for 2019. Dr. Ludwig, the other practitioner of pediatric cardiology in the community, and I saw 2,564 patients. 424 of them, or 16.5%, had either chest pain or syncope or both. The most important thing about these diagnoses is they're almost never related to anything related to the heart. However, the concern is that you don't want to miss the ones that are, because that can have lethal consequences. However, I'm hoping by the end of the talk, most people will understand who have a comfort level that they can handle these patients in their clinic settings. So several things tie these two diagnoses together. One is that the families come in with a huge amount of anxiety. They've seen perhaps their child faint, the child turns gray, they lose consciousness. It's very upsetting. And then the patient with chest pain, people almost automatically think that the patient is having something related to the heart simply because that's what adults present with. Often, particularly patients who have may have a lot of other complaints, such as stomach pain and back pain, a lot of headaches, they often will have chest pain and syncope. And stressors will always make both these conditions worse. from the practitioners, I think most practitioners are terrified that they're going to miss the one patient out of 100,000 or so that's going to have a true cardiac cause and may have an aborted sudden death because of it. So the incidence of syncope countrywide is 15%. This is what most of the literature suggests, between the ages of 13 and 18 years. I personally believe that we have a much higher incidence here, and I will explain a little bit more about that later. Most of the patients will also have what we call pre-syncope, where they feel like they may pass out, but don't actually pass out. And there'll be a lot of patients who only have the pre-syncope and don't actually ever pass out. Most of these patients will have symptoms when they change from a lying position to a standing position, or when they've been standing a while, or just walking. And some will have it just immediately after they exercise if they have not cooled down. And these patients are experiencing orthostatic changes, and those changes in their blood pressure and pulse result in their symptoms. So syncope is defined as the loss of consciousness. I explained already pre-syncope what that means. And patients will report this in different ways. They'll say they're dizzy. Sometimes they'll say they lose the ability to see completely, or they'll see spots. They'll have fading out. A lot of patients will also be nauseous and feel very hot just before they do pass out. So clearly, everybody should be doing a complete history on the patients who come in with this complaint, as well as doing sort of a history of their present illness. But I asked specifically, after I asked my non-leading questions, my general questions, I will ask what happens when people change positions from lying to standing. I asked, do they ever pass out when they've been lying down for a while? That points to a non-orthostatic cause. Some patients will have hurt themselves. They'll have fallen, hit their heads, get injuries when they pass out, and that tends to suggest less. When they don't have that, it doesn't necessarily mean that they aren't having orthostatic changes. But when they do have that, it does suggest that there is something that is in the realm of me treating them. After you pass out, how long is it until you are alert again? Typical orthostatic changes resulting in syncope, patients will be alert very soon, within a minute after they pass out. And then how often does this happen? Also, do you ever shake your legs or arms when you pass out? There, the question is, because I want to make sure that they aren't potentially having a seizure, but also because patients will shake their arms and legs when they pass out, not have a seizure. And if that happens, the families are much more concerned than they would be otherwise. So lots of different names for this very common kind of syncope. We used to be calling it vasovagal syncope. We no longer really use that term because most people don't have as big a vagal nerve complaint. Most people are not really having significant bradycardia. So now we talk about it as neurocardiogenic syncope, which is the term I use, or neurally mediated syncope, which is another common term. So this will also include patients who, when they change from lying to standing, will have a tachycardia. And that's, if they have blood pressure changes, that's referred to as postural orthostatic tachycardia syndrome. There are times, however, that it will be vagally mediated. The breath holders clearly drop their pulse when they and become bradycardic when they pass out. So do the patients who have problems with blood drawing, or when they see blood, or when they suddenly get hurt. But since what we see the most is the people who have orthostatic changes, that's what I'm going to focus on the most. So One of the common complaints I have is that patients feel dizzy with exercise or faint with exercise. And it's really important to ask for those patients if it is while they're exercising or when they have just stopped. When people have just stopped, they had generally been having a lot of muscle contractions, particularly in their lower legs. That helps bring the venous return back up to the heart. And if they stop, then the muscles relax, the blood pools, and they can have symptoms just as if they've gone from a lying to a standing. I will occasionally have people who also feel dizzy when they exercise, and those patients I treat with a little more concern because I do want to make sure they don't have a worrisome cause. So when people stand up from lying down, we refer to this problem primarily as an issue with venous pooling. What happens when people are lying down, it's easy for the blood to return from the head and the neck, which is 1/3 of the blood flow, and from the bottom half of the body, which is 2/3 of the venous return. However, when they stand, there's easy return of the blood from the head and the neck, but the blood from the bottom half of the body has a more difficult time because now you have gravity. And in addition, the teenagers don't have as, their veins tend to be much more elastic, and they tend to have their blood literally pool in the lower extremities. What happens when people stand up is generally their hearts start to beat faster to try to get more blood out to the body, but there's not more blood coming back. The heart has receptors that get triggered, and because of decreased venous return, and that results in a brain signaling to cause the visual disturbances and dizziness. All of this tells the patient that they do need to lie down, and most people will instinctively. If they don't, their blood pressure can drop more significantly, and then after you have a hypotension, you get a bradycardia. So typically the history will be, as I mentioned before, the exam will be normal, with the exception that when you have the patient change from lying to standing, there'll be an increase in the pulse with no change or a drop in the blood pressure. And I usually use the number of 30 beats per minute as that change to be important. Postural orthostatic tachycardia syndrome is something that's coming up very frequently in terms of people coming to the office. In a way, it's become a condition that's a little bit of a catch-all for all sorts of symptoms that patients have. I do try to remind them that the term really is inclusive to mean that the blood pressure stays the same or goes down and the pulse goes up. So why teenagers? We believe the reason is that the teenagers do not they've not completed their growth. And so the brainstem that mediates this has not yet matured enough. And so the venous tone is not as good as it will be when they're older. I will see children younger than teenagers. When they're under 8 or 9 years old, the history has to be very, very clear that that's what's going on. And most patients do grow out of this. I now tell families that they grow out of it in their 20s, but a significant stressor can result in someone still passing out. An example from my practice many, many years ago in a different state is a woman who had had a baby about 2 months prior to when I met them. And I actually was seeing the baby for a different condition. And it turns out that one day the husband found her collapsed in the kitchen. I think he heard her fall. And what happened is she had a history of passing out, but the stress of having a new baby and not getting enough sleep was enough to trigger her to begin passing out again. The husband, by the way, thought she'd just fallen asleep on the floor. So the issue I think most practitioners have is when they want to be sure that this is not a cardiac cause of syncope. We read often about sudden death in athletes. We hear about people having arrhythmias, and no one wants to be the practitioner who has missed that. So you're looking for a different history. You're looking for a history of someone who has had syncope while they're lying down or asleep, or when they're excited. One patient, again, many years ago, was receiving an award, and he passed out as he walked. He had a syncopal episode as he walked down to receive the award in the auditorium. People who pass out while they're swimming, besides it obviously being dangerous to pass out while you're swimming, that is a red flag for a condition called long QT syndrome. So anything that just doesn't fit the picture of changing position or stopping exercise likely deserves a referral. Young kids, they will have breath holding. And I do have a lot of families who come in because the child has breath holding. Unfortunately for the family, there's no treatment for that, but that is another time that we reassure. But if the patient's having syncope without breath holding, and they're 1 or 2, 3, 4, that also should be a referral. Sometimes that's going to be cardiac or neurologic. We've had patients with seizures who also present with syncope. So I just labeled this psychogenic syncope, and this is also something where the history almost leads you down this path. So this is going to be someone who has episodes that they are standing, they're lying down, they're sitting. It can happen all the time. They often will have many, many episodes. A lot of the times they won't be witnessed. Sometimes we've had patients admitted and they will be on a monitor and they won't have any changes in blood pressure and pulse. And this is one of the times that I will do a tilt table test, which I'll explain in a little bit of time. Sometimes also the patient will have a lot of anxiety, or just how they interact with you will suggest that this does not have a cause that's related to arrhythmias or seizures or any kind of orthostatic changes. So the early research, and I think this has been continued, is that some of the cases of psychogenic syncope should raise a red flag, not in a cardiac sense, but these are often patients who really should be evaluated by a mental health practitioner. I've had in the literature, and also I've had experience myself, where I've had women who have been either abused sexually or almost been raped, and they have presented with syncope. Sometimes also there's a lot of family dynamics that has resulted in the family having, the child having syncope. So one of the tests I will do is what's called a tilt table test. And this is where someone's lying down, they're belted in, and they have a board at the foot of the table. The table is raised up to about 80 degrees and the patient stands there. Most of the time, the patient who is going to have blood pressure and pulse changes is going to have symptoms and changes in their pulse and blood pressure because they are not allowed to move. So it gives optimal conditions for the blood to have venous pooling in the lower extremities. When we have people who appear to have had a syncopal episode with no change in pulse and blood pressure, that is usually a big sign that the issue is going to be psychogenic. Where I run into families is that, as best as I tried to explain it, particularly the families that have unusual psychodynamics, the family doesn't want to hear it. And those are patients who go seek out my partner, they go to Loma Linda, they go to Mayo Clinic, they go to Stanford, and we have one patient, I think, who's hit all of those. So malignant causes of syncope, that's where everybody gets really anxious. And I did not put on here seizures, but that would be in the differential. Pulmonary hypertension, when the pressures are extremely high in the pulmonary arteries, that is a set of patients who, when they have syncope, that's actually a very poor prognostic sign for how well they'll do and what their ultimate mortality will be. Hypertrophic cardiomyopathy, that is also something, particularly in the athlete, that they can present with. What can happen is, since hypertrophic cardiomyopathy means that the ventricles severely thickened, they do not have enough coronary blood flow to result in good perfusion of the heart, and particularly when they're exercising, they can have a syncopal episode, or often an aborted or a true sudden death. Atrioventricular block is a rare cause, and I believe is even more rare than some of the ventricular arrhythmias, but that's going to be a history that doesn't fit the typical history. It'll be a patient who does have issues more at any time. One patient many years ago had an episode when he was 2 while he was rocking on a little rocking horse, and then had another episode when he was out buying a Christmas tree with the family, and that patient had a significant atrioventricular block. Coronary artery anomalies, I have had patients who have had syncopal episodes with these. Usually the significant ones, though, again, this will present, unfortunately, with an aborted or a true sudden death. The most common of all these issues is going to be ventricular arrhythmias. That being said, it's something like 1 out of 100,000 patient years. It's very uncommon. The one most practitioners know about is something called long QT, and the EKG can be helpful, but it's not always. Supraventricular tachycardia is a very rare cause of people having syncope. I have seen one patient in my over 30 years of practice that happened. So ventricular arrhythmias are the biggest of the biggest category of the cardiac causes. Some of the names people may know are Brugada syndrome, long QT, short QT, arrhythmogenic right ventricle, and catecholinergic polymorphic tachycardia. These are all rare. Yes, please refer. Long QT syndrome, the QT interval, which is in the EKG, the beginning of the Q wave to the end of the T wave, generally takes too long. And this results in an uneven repolarization of the ventricle, so that the next cardiac impulse that comes down to the ventricle will be able to be conducted through part of the ventricle, but not all of the ventricle, and you'll end up with what's called torsade de pointe, and then VFib. Lots of different kinds of long QT syndrome. What scares most cardiologists is that some of the long QT syndromes don't really have a long QT. And so we're always afraid of missing this. And this is where I go back and I go back and I go back with the history. And this is also where family history is incredibly important. You really want to know not just first degree relatives, but I want families to ask beyond cousins and cousins of cousins, and ask anyone they know to see if there is a history that is suggestive of people passing out, having seizures, unexpected deaths, pacemakers, all those things.
So can I ask a question about that?
Yeah.
So if you can't always see the long QTC, are there certain circumstances that may exacerbate that, in which case you could see it on EKG? Or
yes, so there are also a set of people that also have QT intervals that are very sensitive to medications. For instance, one of the reasons that erythromycin sometimes is a problem, and some of the medications that used to be used to aid gastric emptying, and I'm blanking on the name now, you really can't prescribe because people do get long QT from that. The other thing is that certain conditions in terms of electrolyte abnormalities, overdoses, all those things can cause it. So, and there's some other things on EKG that besides the long QT, and I have an example of that I will point out. So in this EKG, if you go from the left of the screen to the right of the screen, you'll show that the patient's heart rate is slowing down. This is a patient who I met after the tilt table test. This patient had a tilt table test. The indication was that she gets dizzy, and she's never had a syncopal episode, but her mother had had a syncopal episode. And so for that reason, the tilt table test was done. So this was within, I think, 2 minutes of her standing. So here her heart rate goes down. It continues to go down. And remember that each of these pages is about 6 seconds. Here it goes down more. And there it continues to go down. So you can guess that by this time, the patient has had a syncopal episode. So this is a patient who had a slight tachycardia, had a hypotension, and then went into the bradycardia. This does cause panic. If I remember correctly, this was at the time this hospital code was called. It wasn't a pediatric hospital, and by the time that I got there, the child was fine. Usually, immediately, the staff puts the patient down, and the patient gets lots of fluids. It is one of the reasons that I always ask if we're going to do a tilt table test that the patient always is ready to be monitored the second that they are put up. So this patient has something called Brugada syndrome. And what I would like you to look at is, if you look in the midway of the EKG, in lead V1, so red dot.
Oh, just a second. There you go.
There you go. In lead V1, you can see that EKG just doesn't look right. You have a sharp upstrike of the Q wave, but then your ST segment is elevated and drops and becomes negative. It's just very odd looking. And that is pathognomonic for Brugada syndrome. Now, this is incredibly rare. And I've only seen one patient with it. This, by the way, is one of the ones, though, that genetic testing is available. So with patients who don't always have this EKG, we can do genetic testing if we have a suspicion. For the kids, also, their EKGs will look more striking if they have fevers. So I'll have a family member, particularly if there's a concern, I'll have them bring the child in to get an EKG when they have a fever. This is one of the conditions that results in ventricular arrhythmias that can result in death. Okay, we're not moving. Okay, so this is an example of a patient who has long QT syndrome, but the QT interval does not look particularly long. So if we look at lead 2, now it's following me around, the beginning of the Q wave, and then to the end of the T wave, that is not particularly long. So long is considered to be 450 milliseconds in girls and 440 in boys. But what was suggestive of long QT syndrome is the fact that this is a 3-year-old. And typically 3-year-olds come in and they don't have this slow of a heart rate. So bradycardia will be one of the tip-offs. The other tip-off is if you look at the T waves, there's a slow upstroke and a rapid downstroke. And so they also look different. Remember that the computer may not show this. They may not read it as abnormal. So you need to look at your EKGs. And if something strikes you as unusual, many of you have been practicing long enough that it probably is unusual. And also, Dr. Ludwig and I are always happy to review EKGs, discuss cases. But if you are practicing elsewhere, I'm sure the pediatric cardiologists available to you would also be willing to. This is another patient that I learned a great lesson from, which is that it turned out in this patient that there had been no episodes, seizures, passing out or anything in the parents, in the aunts and uncles, and the cousins. But when the family went and explored further, it turns out that the grandfather's brother and his whole side of the family were known to have long QT, known to have sudden death. Many people had automatic implantable cardiac defibrillators, and they had already had a gene identified. So with these kinds of syncopes, I do ask families to ask everybody they know in the family, as far out in their family tree as they can. Another point to make here about family history is the simple orthostatic changes. That kind of syncope also will end up being, can be inherited.
Dr. Van Gilder, did you have a question?
Hi, yes, I had a patient, well, we had a patient in the community out here who was recently diagnosed with Brugada after a sudden syncopal event running in baseball, and his nephew or niece, I can't remember which now, came in and were asking about referral to pediatric cardiology for evaluation. I don't remember the name, unfortunately, but we went ahead and referred, but it was a niece, not a first-degree relative. Is that, from what I was reading, it was like first-degree relatives recommended for Brugada testing. Do you have any suggestions?
So what I would do in that case is I would actually, rather than check the niece, what I would do is I would get genetic testing on the parent of the niece. So the brother or sister, whoever was related to the proband. Sometimes that's hard. Sometimes those individuals don't have insurance, or they just don't want to know. So you end up being stuck with doing the niece. And in that case, clearly an EKG, and depending on the worry level, since we would have presumably an identified gene, we can always get genetic testing. If you're looking for genetic testing and you know what the problem is, you know specifically where there is a change on the chromosome, you can actually ask specifically for that, and that's a lot less expensive to the family. So best, obviously, to get the niece's parent. I don't have that happen often. But I see the kid and the parents or the aunt and uncles are not terribly interested in being tested.
How is genetic testing covered as far, do we have to, in your experience, have you had to send them to genetic counselors to get the testing?
Nope.
Nope.
I believe you can also do it yourself.
Okay.
So if they came to us, we have already a contract with a company called Invitae. There's also a lot of other companies. And what happens is we fill out the paperwork, and then the company themselves will contact the families and arrange things. And then they have usually a saliva test sent out to them, and they send it back, and it's all done. It's much easier than it was 10 years ago. And as I said, most insurances will pay for it. Medicaid in Nevada will not. In the case, however, of a known gene, sometimes the companies are very good, and they'll make it only $200, or sometimes they'll write it off. So it's worth pursuing.
What is the name of the company?
Invitae. It's
Invitae.
INVITAE. And there's also GeneDx. There's a lot of different companies.
Thank you.
And you also can call our office and we can help.
Perfect, thanks.
So this patient was from a long history, a long time ago. And this was a patient where history always isn't helpful. It was a patient who passed out while in a marching band competition. And we had thought that it was simply orthostatic hypotension because you have to stand still. At this time, we were doing tilt table tests on everybody. And when the patient had the tilt table test, the patient started to have multiform PVCs. At that time, we were also giving isoproterenol to everyone, and the isoproterenol started this out. So you can see on the top strip, that is torsade de pointe. That's meaning turning around the point, and that patient has a lethal arrhythmia. She's actually at a hospital by this time. That little pause is when she got shocked, but you can see she does not have a stable rhythm. This patient had identified long QT, had gone to a different practitioner, had gained weight, and had not had an adequate amount of medications to treat it. We used beta blockers. So after this patient got an automatic implantable cardiodefibrillator, and that's what we almost always do in a patient who has an aborted sudden death. So the typical is you're going to see the patient with blood pressure changes on standing up and symptoms on standing up. This is not, all patients are supposed to drink 80 to 100 ounces, water, electrolyte drinks. I ask them to increase the amount for every hour of exercise. Daily exercise seems to help. I don't know if it just helps the venous tone. If they feel like they're going to pass out, I ask them to lie down. Usually patients who pass out will look deathly pale. And as they are feeling better, their color will return. But it's really important to emphasize to families that they should stay lying down. I often have well-meaning family members or sometimes nurses in school who will get the patient up in order to try to board the teacher to try to get them to the nurse's office, and they'll pass out again. Patients should cool down after exercise. And all of these symptoms, like many, many things in medicine, are worse with stressors. One patient I had who had not passed out always felt dizzy at 10 a.m. and 2 p.m. She was a middle schooler, and 10 a.m. was when she had English as a second, English language arts, and 2 p.m. was when she had gifted and talented. She hated the teacher for the English, and she got anxious in the other class. And that family, actually, once they figured this out, she became remarkably better. So psychogenic syncope, if you can get the family to seek mental health counseling, that's very helpful. Sometimes I'll approach the family and say that just the passing out will make them stressed. So that is a way to get the family to consider it. For the malignant arrhythmias, we use beta blockers a lot, but sometimes people need other things. For structural causes, such as coronary artery anomalies, you find out what it is and you treat it. So that could be another 5 hours of lecture. So some patients still have symptoms after lots of food and salt. We choose Florinef, which is a mineralocorticoid. You take it once a day or twice a day. You have to check electrolytes and make sure people eat a lot of sodium and potassium. And my personal favorite is Midodrine. It works where the problem is, which is at specifically it's an alpha agonist, makes the blood pressure better. Now chest pain, and I do realize that we're getting a little short on time. So chest pain, I see a lot of this. I think yesterday I had one syncope and one patient with chest pain, new patients, and that's a typical day. If a patient has palpitations and they are a pediatric patient, that is one of the few things that will make me think of a cardiac cause, because people who notice their heart suddenly racing can have SVT, and this is going to be one of the few cardiac causes of chest pain. If the patient has a sudden onset of severe chest pain, crushing, they look pale, they look sick, those patients may have something like myocarditis or pericarditis. It would be highly unusual for them to have any kind of coronary blockage. But most of the time, the chest pain's not due to the heart. Various papers will give you different amounts. I use the number 0 to 7%. I think the number put in the article that was made available to you may be slightly different. But the cardiac causes are going to occur in patients primarily with the rapid heartbeats. Interestingly enough, the things we worry about, like coronary artery anomalies, where the coronary arteries come off the wrong place, or the hypertrophic cardiomyopathy, or the ventricular arrhythmias, usually present with syncope, not chest pain. Families come in, however, and they're worried because they think chest pain means that the person's having a heart attack. And a lot of times the child will point to the left side of the chest, and that makes them even more worried. So on exam, since most of these people don't have anything cardiac, most of the time all they'll have is pain if you press on their chests. If they do have one of the rare causes of hypertrophic cardiomyopathy or severe aortic stenosis, you might find a hyperdynamic precordium and a murmur. But again, they usually don't present with chest pain. So this is where I end up having to do a lot of reassurance. The numbers I usually quote to the patients, and this will vary, is about 30% or less will have pulmonary cause. That history is going to be pretty suggestive. It'll be someone who gets short of breath when they're running and they have chest pain. Those patients may be patients who haven't had it before. They've been athletes and suddenly this year they present with it after playing whatever sport for years. And I remind them that there always is some change in the allergens around the environment. And so not having had symptoms before does not mean that they don't have exercise-induced asthma. I usually quote 30% of patients will have something like gastroesophageal reflux. If any of you have ever had that, it does hurt in your chest and it's very painful. That history will be someone who coughs when they're lying down, often will have a taste of bile in their mouth, or will have a taste of food hours after they've eaten in their mouth. The last category I sort of think of as a catch-all category. The most common cause of general chest pain, and in this category is something called precordial catch. And one of the articles I gave you was specifically on that because it's so common. That will be the patient who has very sharp, severe chest pain, stabbing, they can't take a deep breath, and it's very short lasting, certainly less than 5 minutes, usually less than 2 or 3 minutes. Also, the catch-all category of the 30 to 40% stressors will make all those symptoms worse. It's interesting with chest pain, I find the families are much more willing to believe in anxiety and accepting of that, not so with the syncope. So precordial catch syndrome, I just did describe this to you. And this is where asking questions like how long the chest pain is, can they describe it, where is it on a pain scale, how often it is, and how is their breathing when they have it. So precordial catch syndrome, lots and lots of testing has been done on these patients and no causation has been found. So the precordial catch part sort of means pre, meaning in front of the heart, precordial, and then catch because it almost is like what maybe I've called a cramp or a stitch. It's a very short acting thing. And I'm able, with reassurance to the families, I'm able to tell them an actual name. I'm able to write it down. Families can go look it up. And it's really helpful in those cases to be able to give them something about giving names. Patients like to have names for things. So we talked about some of the other causes. You know, there's also costochondritis. That one's fairly classic. You push on the junction between the ribs and the sternum, and you'll notice that. And when the patient has chest pain that I can't really identify, it can go on for hours. That time, I'm usually more likely to consider stress as sort of initiating it. Also, another pertinent negative is when patients aren't woken up by their chest pain. So obviously for treatment, you're going to treat the gastrointestinal and the pulmonary as you would treat that system. In the case of myocarditis, where people will have severe chest pain, those patients don't usually come to my office. Those are ER patients. And the history is suggestive. ER doctors also order lots of testing like EKGs and troponin, so there'll be something that also alerts you besides the symptoms. For SVT, we treat the tachyarrhythmia, and in all cases, much time should be spent trying to reassure the family. So as I explained a little bit earlier, I try to make sure the family understands why it's not cardiac. I point out that coronary artery disease acquired usually occurs in much, much older people, and under the age of about 25, it doesn't occur unless they have a known homozygous hypercholesterolemia, and those patients know that they have it way before. And so we talk about that, and we talk about the other causes, and I really spend a lot of time reassuring. In my office, I usually do an echocardiogram, and part of the reason is that the patient's been referred to me, and I feel like that's what partially the referring wants, but I certainly think that no echocardiogram needs to be done. So in conclusion, both these topics are very similar because they're generally not due to the heart, and when they are due to the heart, it's scary, and it scares everybody. Spend a lot of time. These cases take much more time than most of the other patients I see because the amount of reassurance is needed. Also, an important thing that I meant to mention, but it's not in here, is EKGs, particularly for syncope, and EKG has to be done. So I also bring up the comment about stressors, worsening symptoms. Hopefully people understand that and they recognize that. More so, as I said, they recognize that in the case of people having chest pain, but not the syncope. Thank you, guys.
Yeah, so we're going to display just a quick little post survey. So any other questions before we wrap up for today? Feel free to unmute yourself or write it through the chat. Okay, I think we'll finish there for the day. So next month we'll be back Friday, September 13th with a section on child abuse screening. So hope to have you join us then. Thank you so much, Dr. Tripp. This was fantastic.
Thank you.
All right. Have a great rest of your day and a good weekend, everyone.